Hello and welcome to the IMEDX Best of Day series here in San Diego, California at our annual Hematology meeting. It's a pleasure to be with you again. My name is Dr. Joseph McHale. I am a hematologist at Mayo Clinic in Arizona, and with me is my very good friend, Dr. David Steensma, who is a senior physician at the Dana-Farber Cancer Institute and is a veritable world expert in myelodysplasia as well as acute myeloid leukemia. So we're going to be talking about both of those topics today together. David, thank you so much for joining us.
Joe, it's great to be here with you. Thanks for having me.
Excellent. Well, I understand it has been a busy few days in the myeloid world. Hopefully we're going to eventually get beyond 7+3, as I like to say to my AML colleagues. But why don't we start a little bit with myelodysplastic syndromes. I know that a number of larger trials were presented here, including the ECOG trial, which as I understand it has been kind of like a 10-year pregnancy. It's been going on for so long. So can you tell us a little bit about that?
Yeah, so Alan List presented this trial, and I have to give Alan credit. This study really required a lot of persistence to go through a bunch of problems that it had early on where there were concerns about thrombosis evolving with using EPO and lenalidomide together and the usual challenges of doing a cooperative group study. But it finally fully accrued and the data are available. This was a study for patients who were with lower risk myelodysplastic syndromes who were resistant to erythropoietin. And
so they'd proven that resistance prior to enrollment in the study?
Prior to enrollment, or they had a very high endogenous EPO such that they would not respond. Okay. And so patients were randomized to get either lenalidomide alone or lenalidomide plus epoetin. And this was a not del(5q) study, so there's actually all lower risk MDS. This was more prescriptions are written for lenalidomide off-label in the non-del(5q) setting in MDS than on-label, because del(5q), although lenalidomide works much better in that subset, it's an uncommon subset of disease.
And there's evidence of activity in those that do not have the deletion 5, right?
That's correct, yeah. So just this year, the second randomized study was published in JCO, MDS 005, and it has a 26% transfusion independence rate in that setting. That's about 8 to 10 months median. So there is some activity, but it's not nearly as effective as in the del(5q) setting. So
understood. So in this study, all comers, EPO resistance, len-EPO versus just len.
Correct. And the combination was more effective, which I think the take-home message was that len really can resensitize to EPO. And so, that was a useful piece of information for clinical practice, that if we have somebody on erythropoietin, they're not responding, we're thinking about starting len, it may be okay to continue the erythropoietin if the insurer will let us. That's always the
in conjunction
challenge.
With the lenalidomide.
In conjunction with the lenalidomide.
So for our listeners here today, many of whom are oncologists or hematologists, oncologists in community practice, the take-home message is that lenalidomide may be effective, of course, as we know already in MDS, but in EPO-resistant MDS, the potential combination of len plus EPO may further reduce the need for transfusion.
Correct.
Okay, great. Now I understand there was another head-to-head of all the agents that you have in myelodysplasia, that there was a head-to-head comparison of decitabine and azacitidine.
Yes.
Well, how could I forget? Of the huge laundry list. But azacitidine, decitabine. So tell us a bit more about that study.
Well, so we only have 3 approved drugs in MDS, and the 2 hypomethylating agents, decitabine, azacitidine, and lenalidomide. And decitabine, azacitidine have quite similar labels here in the U.S. In Europe, however, azacitidine is only available for higher risk MDS, and decitabine is not available at all for MDS, except on study or by single patient compassionate use. It is, however, approved for AML, which it's not here in the U.S., so it's a little bit of a confusing regulatory landscape. Okay. In any case, these agents have never been compared head-to-head in a prospective trial. And what we'd all really love to see is a trial of higher risk MDS comparing the commonly used 5-day decitabine schedule to the commonly used FDA-approved 7-day azacitidine schedule. We may never see that. This was a study in patients who at the time were lower risk MDS, so IPSS low or intermediate 1, and they were randomized in an adaptive randomization Bayesian fashion to get either decitabine for 3 days a month or azacitidine for 3 days a month. Now, that's important because that 3-day azacitidine may have been a little bit of a mistake. It was actually
a little bit less than you'd normally use, right?
less than you'd normally use, and more of a reduction from the standard dose and schedule. So the decitabine dose was 60% of the typical 5-day dose, whereas the azacitidine was 3 divided by 7, whatever that is, less than half anyway. And so that may have contributed to the results, which were that decitabine fared better. And the response rate to decitabine was better. The event-free survival was better. It's a little bit harder to measure response to these hypomethylating agents in lower risk MDS because you don't have the blasts. You often have a normal karyotype, so you're really looking basically at hematologic improvement, and the drugs are myelosuppressive, so it can be a little bit hard to know what the responses are. Nonetheless, they used international working group criteria as best they could, and the decitabine did better. Now, because of the adaptive randomization, there were a lot more people who got decitabine than azacitidine. It was like 70 to 40. And so there is a follow-up randomized trial that's actually ongoing, comparing 3-day decitabine to 5-day azacitidine to 3-day azacitidine to best supportive care alone. So 4-arm study.
Wow.
And this is going on in the MDS Clinical Research Consortium, which is supported by the Evans Foundation and the Aplastic Anemia MDS Foundation.
So until we obviously don't have the immediate results of that study, from this one, despite the fact that maybe it's not the optimal regimen that you normally use, do you think in practice this will lead to a greater use of decitabine over azacitidine in the lower risk MDS, or do you think the jury's still out on that one?
I think the jury's still out. I do think what it suggests is that in the lower risk patients, if you are thinking about using hypomethylating agent, it may be okay not to do the full 5 days of decitabine. But we don't know with azacitidine what the optimal dose and schedule is in that setting. So we still do need more information. But this is the first time they've ever been compared against each other, so it was worth talking about.
Mm-hmm. But there still, of course, can be used independently or sequentially as they're most routinely used now.
Yeah, so sequentially, often when somebody doesn't respond to decitabine or doesn't respond to azacitidine, they won't respond to the other hypomethylating agent either. There are a lot of folks in clinical practice who do attempt the other just because of lack of other available therapies, but it is not a effective strategy.
Okay. I also understand that there were some other more novel agents being used in MDS, one pretty close to maybe being the next in your laundry list of agents. You want to tell me a bit more about that?
Yes, well, we're certainly jealous of the myeloma doctors who have all these different therapies to choose from now and combinations, and they talk about things like pentarefractory. People have been through 4 or 5 lines of therapy previously. In MDS, it's much more limited, but there is one drug that I think has a reasonable chance at approval, and that's called luspatercept. What it is, it's an antibody that's bioengineered to bind to members of the TGF-beta superfamily. It's an activin receptor 2 ligand trap. And the way that we think that works is it binds to one particular protein called GDF11 that is an inhibitor of late-stage erythropoiesis, so that if you have an anemic individual, turns out even healthy volunteers, their hemoglobin goes up with this agent.
Oh, really? Okay.
It's being tried in thalassemia and other type of anemic disorders. But if you have somebody who is anemic due to myelodysplastic syndrome, you give them this agent, the hemoglobin can go up because that inhibitor of erythropoiesis is decreased, and that block is released. So this agent showed quite promising activity in early phase studies that were presented last year, and that was updated. The patients who went into this study turned out to be mostly those with either ring sideroblasts or SF3B1 mutations. Those are the patient subsets that seem to respond best to this drug, probably because their defect in erythropoiesis is distinct from MDS generally. In MDS generally, it may be much earlier in the erythropoietic development where the defect is BFUE, CFUE stage, whereas in sideroblastic anemia, it's probably later on. because of the iron processing defect. So in any case, quite an impressive transfusion independence rate, over 80%.
Do you think that would be applicable to those that don't have the ring sideroblasts, or maybe in the more conventional MDS?
We don't know. It's very small numbers of folks that have been treated with luspatercept who did not have ring sideroblasts, because just like with lenalidomide, the first 10, 11 patients, it became clear that there was a del5q signal, because two del5q patients responded great, nobody else really responded. And so the trial started to get enriched for del5q patients. Same thing happened with luspatercept. And so there's an ongoing randomized trial called MEDALIST that's comparing 2-to-1 randomization luspatercept versus placebo. It's mostly accruing in Europe. There are a few U.S. sites. And it's to get in, you have to have anemia, and you have to have either ring sideroblasts or SF3B1 mutation, or both. And so
still
if this
focusing in that group.
Correct. If this is a positive study, I think this is likely to be approved. Safety has been pretty reasonable so far. So it can be given as an injection once a month. There's myalgias and such with it, and we don't know about longer-term safety yet, because this is a real new thing. But at least it's an agent that is active in this subset.
And I understand there was yet another, maybe a little bit further down, yet to go, a little bit further to bring it to clinical practice, but there was another promising agent in MDS.
There is, yeah. Guillermo Garcia-Manero from MD Anderson talked about an antibody called OPN305 against toll-like receptor 2. The toll-like receptors are important in innate immunity, and there's some preclinical data showing that expression of toll-like receptors 2, 4, and 5 are increased in MDS. There is a toll-like receptor 2 antibody that's been used in patients who've undergone renal transplant and were at risk for allograft rejection, and so that was the agent that was studied in MDS patients. It was 21 patients. They had previously been failed by hypomethylating agents, so kind of a refractory group. And about half of them had some sort of hematologic improvement. So I think one of the key things for this agent is what happens if we put it in HMA naive patients, or lower risk patients. Are there certain subsets that respond better or not? Infection is always the biggest concern when you screw with innate immunity, but there were no serious infections seen. So, and the safety record's pretty good in the renal transplant.
So still early, obviously not by any means ready for prime time, but if it showed that kind of activity in the more heavily pretreated or the already exposed to hypomethylating agents, maybe we might see more of it more broadly in MDS studies in the future. Great.
Correct.
Well, let's transform, shall we say, from MDS to acute leukemia.
Progress, yes.
Progress. That's right. A regress or progress? Let's talk a little bit about AML. I know that there weren't huge trials that were presented at AML, but there were, again, some promising agents that might be able to change the elderly landscape that we have now. But let's talk a little bit about AML. What was exciting to you in AML this year?
So I don't think there's anything in AML that I'm going to go home, tomorrow and is going to change my practice right now. Okay. But I think what is exciting right now in AML is that it has been a long time since we had a new drug approved. Idarubicin was approved in 1990. It's been over 25 years. Wow. Mylotarg gemtuzumab ozogamicin was approved in 2000, but then removed from the market in 2010. And although there have been subsequent trials showing some benefit to it, its regulatory status is still kind of murky, and we can only get it by sort of compassionate use. So what I think is exciting in AML is that there's a number of drugs that are showing activity in specific subsets of disease, and that I think have a reasonable chance of achieving FDA approval. So that's exciting. There's probably 5 or 6 things that have a chance at in the next 2 to 3 years getting approved.
Can you maybe tell me about 1 or 2 of them?
Yeah, so one of them is CPX-351. This is an agent that is a fixed ratio combination of cytarabine and daunorubicin with a nanoparticle, sort of a liposomal particle that improves its pharmacokinetics and pharmacodynamics. And it showed a survival advantage over conventional 3 and 7 when given in patients with secondary AML, so previous MDS, between age 60 and 75, who were still reasonable candidates for induction. So
high-risk group.
That is a high-risk group. It's a needy group. There was a randomized phase 2 suggesting there might be a survival benefit. They went on, did a phase 3, and it was positive. So, so this agent, in some respects, yes, maybe it's old wine and new wineskins. It's two drugs we know already, but if we can give it in a way that's safer or more efficacious, that's great.
And so was the safety profile acceptable when compared to those agents used individually?
It was. The count recovery in a number of patients took a little bit longer, but there wasn't a difference in terms of induction mortality that was consequential. So it seems to be similar in terms of its safety. And it's really pretty. It's kind of this very purple color.
Oh, wow.
Very bright. Just like
as
the tie,
evidenced by my tie
Yeah.
today, I'm supporting the purple cause. So that's great. Well, before we wrap up, David, why don't we think about one more novel, potential novel agent in acute myeloid leukemia?
So, we heard updates of both the IDH1 and IDH2 inhibitors, AG120 and AG221, both of which have about an 18% response rate, complete response rate. And then there's a number of other patients that have cytoreduction and then are able to bridge to transplant or some other therapy, but don't meet criteria for CR. And we saw some data presented about molecular responses, and there are a few patients that have durable responses. Some individuals who've been in a CR didn't have other options beside these agents on a once-a-day oral agent for more than 2 years. So there are certainly some patients who really seem to get benefit from these agents.
I remember you and I even having a conversation about this not long ago, about the IDH1, IDH2. There was kind of this excitement about it, but we needed more data. So do you think that groundswell is significant? Do you think that we're going to be able to see these IDH1 and 2 inhibitors in the near future?
Yes, I'm hopeful. These were both single-agent studies, and combination studies are ongoing, adding them to hypomethylating agents, adding them to 7 and 3. And that's actually a more general theme in AML. Right now, there are important studies going on adding venetoclax, ABT199, to hypomethylating agents and to induction. Some very promising results initially with the venetoclax combination. Adding vadetuximab, SGN-CD33A, and other agents. So that NET8 inhibitor, a nuclear exportin inhibitor. So I think that's really the way the field is going, adding additional agents onto the hypomethylating agent and induction background that we already have.
So we're not giving up 7+3 yet, is what you're telling me.
It's not going away, but it may be augmented.
Maybe augmented. All right. Well, thank you so much, David. This was a great conversation, very informative for me, and I trust our audience has similarly enjoyed this today. Thank you very much for joining us here at our Best of Day series with IMEDx. We look forward to having you again at future activities that we share with you, and thanks again for being with us.